left main and multivessel concept change septic ischemia study. So you know that Dr. Bangalore from the United States, we have distinguished panels here. Antonio Colombo, everyone know that. Benny here, Dr. Chan, Dr. Jang, Ik-Kyung, Dr. Jafary, Dr. Kim Moo-hyun, Jang Jae-sik, and David Taggart is here. Thank you for coming. All right. So we're going to have a first talk from Dr. Bangalore. Left main and multivessel disease, revascularization 2023, guideline and beyond. Please.
Thank you very much, and thanks for the invitation. It's great to be here, and thanks for all of you to sticking around towards the end. So I'm going to briefly discuss about left main and multivessel revascularization, specifically focusing on ischemia, and the rest of the speakers are also will be talking about PCI and CABG. So I'll try to avoid direct comparison of PCI CABG for this part of the talk. We'll come back to that later. So these are some of my disclosures as it relates to this particular talk. So in terms of left main and multivessel disease, we are primarily be focusing on patients with stable coronary artery disease. So if you ask ourselves in patients with stable coronary artery disease, what are the overarching goals of revascularization in patients who have stable coronary artery disease? Some of the overarching goals are to improve survival. So let's look at data to support revascularization to improve survival in overall cohort. We'll then focus on high-risk group of patients. The reason I chose these 5 high-risk group of patients is because the prior ACC/AHA guidelines use this as high-risk subsets of patients where revascularization has been shown to have a mortality benefit. So we'll particularly focus on these group of patients. So overall, if you look at stable coronary artery disease, whether it's COURAGE trial, BARRY-2D trial, or FAME-2 trial, one commonality of all of these trials is there has been no significant difference in death, overall death, with the strategy of revascularization when compared to medical therapy trials. Even in the ischemia trial and the ischemia CKD trial, if you look at the endpoint of all-cause mortality, there was no significant difference between invasive and conservative strategy in the ischemia trial, and the curves actually superimpose. There is no crossing of curves. The curves superimpose. The same was true in ischemia CKD trial. Last year, we presented the ischemia extend, where we are following the ischemia cohort. They will be followed up until 2026 for a total of 10 years. This is the interim results that are on 7 years follow-up. And again, for all-cause mortality, you can see that the two curves are still superimposed. There is no separation of curves, no significant difference in death between invasive and conservative strategy. What is interesting is the fact that in the ischemia extend at 7 years follow-up, invasive strategy significantly reduced cardiovascular death. There is a 22% reduction in death with invasive compared to conservative strategy. This translates around a reduction in cardiovascular death of around 0.3% per year. So why did we not see a difference in overall mortality? The reason we did not see an overall difference in mortality was the benefit of reduction in cardiovascular death was counterbalanced by increase in non-cardiovascular death, so 44% increase in non-cardiovascular death with invasive and compared to conservative strategy. So in terms of going back to looking at cohorts where we can improve survival in stable coronary disease, overall survival is similar compared to medical therapy, but there is a small reduction in cardiac death with revascularization when compared to medical therapy alone. So, and again, I must emphasize this reduction in cardiovascular death is not trivial. But let's look at the high-risk subgroup of patients. What about patients with left main disease? If you look at the data for left main disease comes from CABG versus no CABG trial done in the 80s. And if you look at this meta-analysis, the biggest benefit of CABG is in the subgroup of patients who had left main disease. So there is an extension of survival by 20 months if you follow in patients who underwent CABG compared to no CABG at a median follow-up of around 10 years. But it's important to also point out that this is based off of 150 patients who are enrolled in randomized trials. So for left main disease, clearly revascularization reduces mortality. There is a survival benefit of CABG, but this is based on older trials of 150 patients. Well, what about for LV systolic dysfunction? This was studied in the STITCH trial, where patients were randomized with an EF of less than 35 to bypass surgery or medical therapy. And at 10 years of follow-up, bypass surgery reduced mortality when compared to medical therapy alone. Number needed to treat of around 14. We looked at a patient, ischemia excluded both patients with left main disease and also patients with EF less than 35. But we did have patients in the EF between 35 and 50 or who had a history of heart failure. And here, as you can see, if a patient has a history of heart failure or LV systolic dysfunction, invasive strategy was associated with significant reduction in primary endpoint and also cardiovascular death or MI. So in other words, the ischemia heart failure cohort seemed to behave more like the STITCH and STITCHES, where there is a benefit of an invasive strategy. What about patients with triple vessel disease? Here, if you look at the CABG versus no CABG trials back in the 80s, again, triple vessel disease derived significant mortality benefit with bypass surgery, extension of survival by around 6 months. But again, in the 80s, there was hardly any medical therapy. Now, if you look at the Barry 2D in 2009, where there was some medical therapy, diabetic multivessel disease patients, now if you take the same CABG compared to medical therapy, no significant difference in overall survival. In the ischemia trial, we looked at the extent of coronary disease and to see if there is effect modification based on severity of coronary disease. In the patients who had triple vessel disease, the Duke 6 group of patients, there was significant reduction in CV death or MI with invasive when compared to conservative strategy. There was no significant difference in mortality, but the difference seems to be driven by a significant reduction in myocardial infarction. What about proximal LAD disease? In the ischemia trial, whether patients had proximal LAD disease or not was not an effect modifier, and there was no heterogeneity of treatment effect based on proximal LAD disease status. What about extensive ischemia? Again, in the trial, whether the patient had severe ischemia, moderate ischemia, mild or no ischemia, there is no significant heterogeneity of treatment effects, so no significant difference in invasive conservative strategy based on extent of ischemia. What are the other overarching goals of revascularization? It's also not just to try to see if we can reduce mortality, but mainly also to prevent other cardiovascular events. In the trial, we showed that invasive strategy significantly reduces spontaneous MI, 33% reduction in spontaneous MI. We also showed that invasive strategy reduces cardiovascular stays, and these stays were driven by reduction in stays for myocardial infarction and also unstable angina. So invasive strategy does reduce spontaneous MI and stable angina and lowers cardiovascular stays. And finally, the other overarching goals of revascularization to improve quality of life. And in the ischemia trial, quality of life was significantly better with invasive strategy when compared to conservative strategy. And this was long lasting up to 4 years of follow-up. But of course, if the patient is asymptomatic, you're not going to make this patient feel better. So to summarize, there is data to support revascularization to improve survival in patients with left main disease, LV systolic dysfunction, mainly by CABG. There is a small reduction in cardiovascular death, what was seen in the ischemia trial. Invasive strategy also reduces spontaneous MI, unstable angina, and lowers cardiovascular stays. And there is faster and more durable relief of angina in symptomatic patients. And finally, going to the 2021 ACC/AHA guidelines, for left main disease, CABG is a class 1 recommendation to improve survival. So if you're focusing just on survival, as was pointed out in patients with triple vessel disease, both CABG and PCI, it's a 2B to improve survival. But there are many other reasons to do revascularization on these patients, and this is covered in the 2A recommendation, where revascularization is reasonable to reduce the risk of spontaneous MI, unplanned repeat revascularization, or cardiac death. Thank you for your attention.
Thank you. So move on. Second talk. Duk-Woo from some medical center. So insight from all data about the main revascularizations, MAINCOMPARE, syntax PRECOMBAT, novel Excel study.
Okay, thank you. So, and my topic is about, is brief summarized all available data about the left main revascularization. This is my disclosure. So, and over the last 20 years, many trials was conducted for left main and multivessel disease. And for instance, Syntax, PRECOMBAT, and Excel, and Noble trial, there was some remarkable advance of a PCI part as well as a bypass surgery part. So, and looking at the first and the multivessel disease and the Syntax and BEST, Freedom, and the recently FAME3 trial, all trial consistently bypass surgery was better. For left main disease, there is a slightly different, and the Syntax left main, PRECOMBAT, Excel, and Noble trial, different primary endpoint, and the Syntax, PRECOMBAT, Excel, no difference in primary endpoint. Noble was better bypass surgery. So, and in Assam team, we did a lot of the registry and clinical trial in left main and multivessel disease, and we published nearly 15 years ago, MAINCOMPARE registry in New England Journal of Medicine, PRECOMBAT for left main, FAST for multivessel disease. Recently, we performed the 10-year follow-up, and the PRECOMBAT 10-year report shows the primary endpoint, the death stroke, MI, TVR, no statistical difference, and the main difference was ischemic-driven TVR published in the circulation. And recently, TCT best 10-year report reported in multivessel disease giants versus bypass surgery, and no difference, death stroke, MI, TVR statistically, some difference, and repeat revascularization. So, and the left main and the bypass surgery controversy is Excel issue, is a mortality difference, although primary endpoint up to 5 years, some crossover, no statistical difference, and the all-cause mortality was better for bypass surgery, and this was criticized, some not for secondary outcome, not adjusted multiplicity, not designed for hypothesis testing. The reason why we do IPD meta-analysis, this is published in the Lancet Journal, and Mark Sabatin Timmy group involved merged the individual patient level analysis, Syntax lab main, PRECOMBAT, Noble, and Excel trial was individual patient data was summated, and the overall mortality, PCI versus bypass surgery up to 5 years, no difference at all. Up to 10 years in the Syntax and the PRECOMBAT, no difference. And stroke was initial part, bypass surgery was higher, and after later part is no difference. And there is some difference for procedural and spontaneous MI, and by definition, protocol definition, and procedural MI much higher in bypass surgery. By contrast, spontaneous MI much lower with the bypass surgery during long-term follow-up. And this IPD meta-analysis and the intermediate Syntax score and the PCI versus bypass surgery in left main disease up to 5 years. Some trial reported 10 years, no statistical difference in survival. PCI associate lower early stroke, bypass surgery associate lower spontaneous MI during follow-up and repeat revascularization. So, and this is updated, and the ACC-AHA guideline issue after Excel left main disease bypass surgery is class 1. And the PCI could be optional, is 2A, and the ESC not yet updated, and this is issue before Excel trial, bypass surgery is consistent class 1, and according to Syntax category, PCI is 1, 2A, 3. So, and there are still unmet need, and no further clinical trial comparing PCI bypass surgery for left main is not planned. We should still some unmet need. This is a review article published in JACC Asia. Is unmet need about the left main revascularization concept of MI definition still controversial, and the complete or incomplete revascularization. A lot of IVUS or FFR in left main revascularization not fully evaluated. All-cause mortality versus cardiac mortality adjudication, we should consider. Long-term follow-up data of a big trial beyond the 5 up to 10 years is absolutely required. A lot of Syntax score still questionable. And what is unknown, and we absolutely require further trial long-term treatment effect, bypass surgery versus state-of-art PCI with imaging and physiology concept. Some comparative outcome require diabetic, heart rep, distal left main, and the reasonable threshold for incomplete revascularization. optimal stent strategy is still ongoing, and optimal antithrombotic strategy following complex PCI, especially in the Asian population, is required. So also is a big deal is how can the equalized left main PCI technique. This is a US data in the left main PCI overall procedure just occupied 1.0% in United States. This over the time slightly increased 0.7% to 1.3%. This is daily practice. That means in US operator level analysis per year, they just do 0.5 PCI, and the annualized left main PCI volume per center, just 3.2 PCI per year. This is absolutely quite small. We cannot generalize. We cannot, average in the all PCI, the technique in every center. So, and the absolutely next version is a state-of-art PCI and imaging and physiology. IBUS has important role. FFR also has a very important role. Next, future left main PCI could be adapt imaging and physiology concept. So, and the hot team discussion, that is the most important. We should discuss our cardiac surgeon closely and each benefit and its advantage, disadvantage, also consider lots of things. So this is my key summary and the data understanding my practice 2023 for left main revascularization. Remarkable advancement in PCI, clinical outcome of left main PCI substantially improved. Contemporary evidence demonstrate PCI was comparable to bypass surgery in mortality and hard clinical endpoint. Imaging and physiology guide contemporary state of left main PCI will provide much better clinical outcome owing to gap between clinical practice and available clinical evidence. No uniform algorithm can be applied various clinical scenario. Therefore, decision making should be on case-by-case basis and hot team approach should be emphasized. Thank you for your attention.
Thank you very much. That was fantastic, and we continue to learn from all the trials here. So the next talk is going to be insight from all data for triple vessel disease from the man himself, Dr. S.J. Park.
Thank you. Dr. Bangalore has already reviewed for the ISCHEMIA study. It's almost perfect, and so I skipped a lot of my slide here. All right. ESRC guidelines still the PCI for the multivessel disease and allowed in the low syntax score, class 1A. If you look at the 2021 ACHH guideline changed, multivessel anatomical suitable PCI over bypass surgery, if not medical treatment is okay. However, suitable anatomy concern main issue is ejection fraction less than 50%. If candidate for bypass surgery, class 1A, 2A, in case of a low ejection fraction, and if not suitable for revascularization is, medical treatment and PCI would be okay. What is the anatomic suitability for PCI? All ischemic region, diameter stenosis is more than 80%, reference diameter is more than 2.25. FFR and I strongly recommend it. Anatomy suitable for bypass surgery, all coronary arteries with more than 70% stenosis, size-wise more than 1.5 millimeter in diameter, should be revascularization, and functionally all ischemic areas should be grafted. Okay, so low ejection fraction less than 50% is only important index to do bypass surgery. Actually, in ACH guideline didn't mention about too much about the usefulness of the syntax score. Decision making is less clear because of the observed variability, and its calculation is absence of clinical variables. And so Bangalore showed all the data, low ejection fraction, 2 study, CAS trial, Stitch study, very old CAS trial, they randomized very simple lesion, 1 or 2 vessel subset. Anyway, surgery versus medical treatment, all cause deaths no different at all. However, the patient who had a low ejection fraction less than 50 and 3 vessel disease may have benefit in using the bypass surgery compared to the medical treatment. Stitch trial, the patient who had ischemic cardiomyopathy, ejection fraction less than 35%, 600 patient, mean ejection fraction 27%, 10 years follow-up data clearly separate as, all-cause death is better in bypass surgery here. So the reason why low ejection fraction less than 50%, less than 35% is clearly bypass surgery is better. So clear, 3 vessel, low ejection fraction. However, issue is the 3 vessel disease with a normal ejection fraction. Actually, if you look at the guideline concern, is even in the bypass surgery, PCI, any revascularization to B class, that to be weak benefit might be reasonable, might be considered. You may know that. Based on the ISCHEMIA studies, Dr. Bangalore presented all the data. More than 5,000 patients separated invasive and conservative treatment. Primary outcome, absolutely no difference at all. In terms of all deaths, no difference. Recent extended 7 year, ischemia extended 7 years, all deaths absolutely same. Cardiovascular deaths a little bit higher, going to be the conservative. Non-cardiovascular deaths is a little bit higher invasive. However, all deaths absolutely same, no difference at all. No, so ischemia, main message from ischemia, no survival and ischemic event benefit of invasive strategies as compared with the conservative treatment. Optimal medical treatment is good enough in many cases. So still we have limited data. Controversial issue, PCI versus bypass surgery for multi-vessel disease, very limited data, very 2D freedom, syntax, best study. And syntax sub-study clearly demonstrate bypass surgery better, 10 years follow-up, all deaths, best. The only data, actually, 10 years follow-up, PCR versus surgery, absolutely no difference in all deaths-wise. And we have some message from our 10 years long-term follow-up data best. Very 2D study focus on the diabetics, low risk, actually no difference, PCI versus medical treatment, high risk, diabetes and bypass surgery would be better. This is freedom study, CAB is better than PCI. And individual patient level meta-analysis, multi-vessel, in disease of multi-vessel, all deaths is clearly better bypass surgery. However, if you look at the in detail, just only related to diabetic patient, bypass surgery is better. However, with the non-diabetic, absolutely no difference at all. So, what would you do that? Or this is conclusion from the guideline, multi-vessel disease. Bypass surgery and or PCI for patient with multi-vessel disease may be considered to be, class. Patient with diabetic who has 3-vessel disease should undergo bypass surgery 1A. If they are a poor candidate for bypass surgery, PCI may be considered 2A evidence. However, that we have very limited data, all study very 2D freedom syntax, all, DES or bare metal stand-though, lack of a concept of physiology imaging for the PCI, and still lose of issue of complete revascularization concern. And so I would say future perspective, physiology and image supported contemporary PCI, it would be totally different world. And so I really like this syntax 2 study. They did almost 100% IFR, FFR, and 80% IVUS guided procedure, and reduced number of lesion treated 3-vessel decrease, and finally, image guided, IVUS function guided PCI, syntax 2 PCI is clearly almost same with the conventional surgery. There is a big, message from the syntax 2 trial, and the totally different strategy had totally different clinical outcome compared with the conventional angio-guided. Recent published lot of FFR-guided study, famously flower MI, future record FLAB study, including flavors, several shapeless study cannot break up basic concept and the benefit of a contemporary PCI, physiology in images supported. And so my approach for multi-vessel disease, all right, to B class, any revascularization with, guideline-directed medical treatment. So revascularization plus medical treatment, we have individualized according to the different coronary artery severity concern is clearly better. In group with the high risk, 3 vessel disease, 2 vessel including proximal LAD, those kind of high intermediate risk patients, we're going to do revascularization with the medical treatment, and low risk patients, medical treatment alone quite enough. We have to know that. So, summary. All ischemic lesions, favorable anatomy for PCI. What is the favorability? The reference vessel diameter more than 2.5, long lesion less than 50 millimeter, ischemic complete revascularization would be okay. And unfavorable anatomy, it's a possible major vessel PCI, including the proxy with optimal medical treatment. In case of a poor anatomy, low ejection fraction, diabetic patient, we have to consider bypass surgery. So still, we have no data. Contemporary, so functional and imaging-guided PCI versus bypass surgery for multivessel disease, ischemic cardiomyopathy, contemporary PCI versus bypass surgery for multivessel with the diabetics. We need more data. So we just started defined DM trial, the diabetic multivessel disease, one-to-one randomization with the imaging and physiologic guided state of art PCI versus conventional bypass surgery. Thank you for your attention. Medical. All right. So after the have a discussion time. The case presentation. No. Medical therapy is Dr. Bangalore will give us.
Okay, thank you. So, when I first saw this, that I'm debating Dr. Taggart, I was, I didn't know what to do. So I did ask some people who knew David and asked him some advice on how best to debate him. And this is the reaction I got from people. So this was not looking good. So how I really feel about this debate, this is exactly how I feel. So David, I must say I concede. Let's make this debate very short. I'm going to concede. You're right. Surgery has to be the standard for all multivessel disease. And I kind of will do your work. I'll try to substantiate why surgery has to be the standard for all multivessel disease, because surgery improves survival in patients in multivessel disease. And it's important. Ischemia results does not apply to CABG. And medical therapy or PCI does not reduce MI, but surgery does. So let's kind of look into all of these. But before we start, we're talking about stable coronary disease. And in terms of management of these patients, we have multiple options. One is optimal medical therapy. And we know optimal medical therapy targets not just significant stenosis, the 70% or greater stenosis, but also all non-significant stenosis. So this is critically important. Atherosclerosis is a systemic condition, and it needs a systemic treatment. And the only systemic treatment we have currently in our armamentarium is medical therapy. I think this concept is very important. Neither PCI or CABG are systemic therapies for a problem which is systemic. The other options we have for stable coronary disease is bypass surgery. It targets significant stenosis, but also non-significant stenosis, the first 50 millimeters, which are bypassed by the bypass grafts. And surgeons will tell you, if you look closely at this, if you stare closely, the lemur to LAD is still patent. And I'm sure all of us as interventionalists, I have great respect for lemurs, and I think this is one of the best form of revascularization that we can give our patients. In terms of PCI, what we are doing is part treating a systemic condition. So we are only targeting significant stenosis. So PCI without medical therapy is as if we are doing this. We are trying to put a tape on a rather systemic condition. I also want to extend that CABG without medical therapy is similar to this, except we are using a bigger tape, trying to cover some more part of the lesion. So medical therapy is critically important. But there are trade-offs between medical therapy CABG and PCI. Medical therapy has medication-induced side effects. CABG is invasive. PCI, minimally invasive, but it's still, there is a procedure involved. So let's go back to what we said. I want to show that surgery has to be the standard of care. CABG improves survival. Where do we have the data from? So one of the data, of course, is the Stitches trial, EF less than 35%, randomized to CABG versus medical therapy at 10 years, clearly benefit of bypass surgery at improving overall survival compared to medical therapy alone. But I must say, look, I mean, we know this. Ischemic cardiomyopathy did do great with CABG, so let's move on from this. And I just want to make sure the question we are not debating is, does CABG improve survival in patients with multivessel disease and reduced LV systolic dysfunction? The reason we are not debating is Stitches are already proven that CABG does. We are also not debating whether CABG improves cardiovascular death, because ischemia clearly shows that invasive strategy, whether it's PCI CABG, has a small reduction in cardiovascular death. So the question we are really debating, and I hope Dr. Taggart does it too, is does CABG improve overall survival in patients with multivessel disease and preserved LV systolic dysfunction? So where did the guidelines get this data from that CABG reduces survival in these group of patients, the prior guidelines? The prior guidelines got it from this meta-analysis, which was combining 3 trials of CABG versus no CABG done in the 80s. And what we can see here is CABG reduces mortality when compared to no CABG. What we want to clearly observe is there is a high upfront risk, and also the curve starts converging around 10 to 12 years, and you see the absolute reduction here is somewhat reduced. So in terms of, although this study showed that there is a survival benefit of CABG when compared to no CABG, the relationship of CABG with survival is somewhat of a U-shaped curve. You have high upfront procedural risk, then there is a long period of benefit, 5 to 7 years, and then there is a late risk when the graph starts to go down. So we saw some benefit back in the day when there was no medical therapy. So now let's sprinkle a bit of medical therapy. I'm not saying let's sprinkle PCSK9 and all of the other therapies we have. We'll just only sprinkle some antiplatelet therapy and statins and see what happens to this equation. So when you start doing that and now move into modern trials, there is a significant, as was shown before, no difference in death between revascularization and medical therapy. And we also saw this data, no significant difference in the ischemia trial for overall death. This is a meta-analysis of 14 trials, 15,000 patients. Again, no mortality difference between revascularization versus medical therapy. And this is also true for CABG. So if you look at CABG Barry 2D trial, CABG versus medical therapy, no difference in overall death. And Dr. Taggart might say, this is only 5 years, show me 10-year data. So here is 10-year data of MASS2 trial, PCI CABG and medical therapy, CABG and medical therapy for overall survival, no significant difference. So going back to the drawing board, the fact that CABG improves survival is a fallacy. It was seen in older trials with more medical therapy, and the curves actually converge at 10 years. What about the notion that ischemia results does not apply to CABG? So this is all of the trials of revascularization versus medical therapy. We're not focusing on PCI versus CABG trials. This is revascularization versus medical therapy. We talked about the trials at the bottom here where the CABG was shown to have a mortality benefit. If you look at all of these trials, the number of patients who underwent CABG is far greater in ischemia than any of the prior trials of revascularization versus medical therapy. And in fact, this is a table which is a summary for the endpoint of death, looking at contemporary trials and older trials, and whether there is a mortality reduction in CABG. So overwhelmingly, you see that the answer is a no. There's only one trial, the European trial, where there was a mortality benefit with CABG, and that has a p-value of 0.02. I also find it fascinating, I mean, if you look at the surgeon's reaction to ischemia and ischemia extend, when we published ischemia where the trial was negative, the first reaction we got from surgeons were ischemia results do not apply to CABG. And last year when we showed ischemia extend where there was a CV death benefit with invasive strategy, the same surgeon said like all of this result, the benefit must be due to bypass surgery. So going back to the drawing board, ischemia results does not apply to CABG. It's also a fallacy. More patients in ischemia underwent CABG than any trial of revascularization versus medical therapy. What are the fact that medical therapy or PCI does not reduce MI? We know multiple randomized trials, medical therapy reduces cardiovascular death and MI. In fact, there are newer therapies in the pipeline. We didn't talk about PCSK9, SGLT2s, canakinumab, etc. All of them have been shown to reduce cardiovascular events, and which were not actually incorporated in current trials. I'll skip this in the interest of time, but in terms of revascularization versus medical therapy in the ischemia trial, significant benefit of reducing spontaneous MI. We also showed that the type 1 MI was reduced both by PCI and CABG, so it's not just CABG, but PCI is also reducing MI. In the meta-analysis of randomized trials where the revascularization modality was mainly PCI, again, significant reduction in spontaneous MI. I mean, I must say the fact that PCI doesn't reduce MI is again a fallacy. Multiple studies have shown that. What I want to say again is the question we are not debating is, does CABG improve survival in patients with multivessel disease and reduce systolic function? In the 2021 guidelines, we've already given CABG a class 1 indication to improve survival in this group of patients. We're also not debating where does CABG improve CV death. Again, we know from trials that it does reduce CV death, so there is a 2A indication. The question we are debating is, does CABG improve survival in patients with preserved systolic function? That's a 2B. I want to leave my final thought that medical therapy, I must add, with or without PCI, is enough for most patients with multivessel disease and preserved LV systolic function, with CABG reserved for those with complex coronary disease. Thank you for your attention.
Okay, 콘 side, surgery is still standard. David, Taggart. Thank you for coming.
Thank you, Mr. Chairman. Thank you to the panel. Let me start by thanking both Dr. S.J. Park and Dr. Duk-Woo Park for the great invitation to come to this absolutely superb meeting. I have 8 minutes to convince you in this great debate on multivessel disease why surgery is still the standard. Now, although I'm a cardiac surgeon, I will try and present all the data in the most relevant and balanced way possible. I do have some commercial interests, but none of them relevant to this presentation. Whenever we look at any trial of PCI versus CABG, there are always 3 things you need to establish clearly in your mind as you look at data. The first is, who are the trial patients? Are they actually typical of what we do in routine clinical practice, or are they very highly selected? Because that is usually what happens in most trials, and therefore underestimates the benefit of CABG in routine practice, which would apply to most patients with severe coronary artery disease. The second is duration of follow-up. This must be a minimum of 5 years. Ideally, should be 10 years, because what you always see is with increasing length of follow-up, there's an increasing and accelerating benefit of CABG. The third question to ask yourself is, did the CABG patients get optimal medical therapy? Because while they always do better than the PCI patients, most CABG patients are not treated with optimal medical therapy. And a general tip is, when you ever examine a manuscript, always look at the data yourself before you read the text, because the text will often have a pro-PCI bias, and this is almost invariable in cardiology studies. Now, I want to say a few words about the ISCHEMIA study, because we've heard a lot about it, and it's going to be very important in what happens in future clinical practice. So, a randomized trial of initial conservative versus invasive management of stable ischemic heart disease. It's been widely interpreted as a trial of optimal medical therapy versus revascularization, but it's not. But there's a key few things to point out about ischemia. Of the 50 authors, there was a single cardiac surgeon, and the relevance of that will become clear as we go through this. There were 8,518 patients enrolled at 320 sites over a 5.5-year period. So that means on average, each site enrolled 5 patients a year, and after exclusions, each site actually randomized 3 patients a year. The trial patients were predominantly low-burden coronary artery disease. The mean ejection fraction was 60%. But if you look at what happens in CABG in real life, 2/3 of CABG patients were excluded from the outset. Left main, acute coronary syndromes, reduced EF, heart failure, and patients highly symptomatic despite optimal medical therapy. The follow-up was too short, a median of 3.2 years. There'd been no mention of the large numbers of crossovers. 20% of the conservative group actually had revascularization, and 20% of the invasive group had no revascularization. Revascularization was all lumped together with PCI versus CABG, despite 42% of the patients having diabetes. But lumping PCI and CABG together, as I will show you in this lecture, is completely inappropriate. PCI has been repeatedly shown to have no benefit over optimal medical therapy. Look at Courage, Barry 2D, several other studies. In contrast, CABG, as I will show you, has been consistently shown to be superior to PCI, and especially over the longer term. Syntax, Freedom, Fame 3. So I think the construct of the ischemia trial was severely flawed from the outset, and that's probably because there was only one surgeon on the panel of 50 people. And I think the title is highly misleading, as it actually refers, what happened in ischemia was to a very highly select population, but that is not reflected in the title. And the results of ischemia, as we've heard, have been to downgrade guidelines, and this is to the enormous detriment of patients with severe coronary artery disease. Because by downgrading CABG from a 1A to a 2B, that means many patients with severe anatomical coronary artery disease will no longer have the option of bypass surgery. I think this is a very dangerous position. If we look at the Syntax trial, which none of the other panelists barely mentioned, the most definitive trial of PCI versus CABG, and why was it so important? Because unlike all the other trials, it was a relative all-comer trial. And what did Syntax show at 5 years? It showed a highly significant reduction in death, cardiac death, myocardial infarction, the composite endpoint, and the risk of repeat revascularization, and no increase in the risk of stroke. And why else is it important? Because it showed us the importance of the severity of coronary artery disease. In the low severity group, there was a 1% survival advantage of CABG at 5 years, but in the intermediate group, it was 7% at 5 years. In the higher risk group, 9% at 5 years, and these were actively diverging. And although Syntax is now ignored because people say it was a first-generation drug-eluting stent, I will show you that's completely irrelevant to what happens when we're revascularizing patients. I can show you any number of studies which consistently show the benefits of CABG over drug-eluting stents. This is from Dr. Park and Seroy's, and they concluded in their study, CABG as compared with PCI with drug-eluting stent significantly reduced the long-term risk of mortality in non-diabetic patients with multivessel coronary artery disease. And what else is important is if you look at these survival curves, you can see that they're actively diverging at 5 years. So it means it's still underestimating the long-term benefit of CABG. If you look at 3-vessel disease, this individual patient data analysis of 11 randomized trials by Stuart Head, 7,040 patients, relatively selected because the mean Syntax score was still relatively low at 26, but you can see a very significant survival advantage at 5 years that is continuing to accelerate. If you look at Syntaxes at 10 years, we can see in almost 1,100 patients, these patients with a Syntax score of 29, the increased hazard ratio for PCI at 10 years was 40%. So let's look at what Fame 3 taught us. And Fame 3 was a non-inferiority trial of 1,500 patients with 3-vessel disease, and it was designed to address the limitations of Syntax, which had used a first-generation drug-eluting stent. So Fame used FFR-guided PCI and the best available drug-eluting stent. The median Syntax score 26, the composite MACE, the primary endpoint at 1 year was of death, MI, stroke, repeat revascularization, with a relatively wide non-inferiority margin upper limit of 1.65. At 1 year, MACE was 10.6% in the PCI group, 6.9% in the CABG group, so this trial did not reach ability to say the level of non-inferiority for PCI versus CABG. And if you look pictorially at it, we can see that at 1 year there's accelerating divergence between PCI and CABG. And if you look at almost every subgroup, CABG was better, except for patients with Syntax scores of 0 to 22. If you look at patients with diabetes, the most definitive trial addressing this is the FREEDOM trial. It's rarely mentioned. People like to talk about an old, much weaker study, Barry 2. What did FREEDOM show? It showed that a very significant reduction in mortality in favour of cabbage over PCI at 8 years. And the authors concluded patients with diabetes and multivessel disease, cabbage leads to lower all-cause mortality than with PCI drug-eluting stents and long-term follow-up. And these were not the patients with the most severe diabetes, they were an intermediate group. What also FREEDOM showed us was the authors concluded cabbage is superior to PCI for every level of syntax score. They concluded cabbage should be the preferred method of coronary revascularization regardless of the complexity of coronary artery disease. Yet we know in clinical practice this is very widely ignored. We've heard about the STITCHES trial twice, just to say that in patients with ischemic cardiomyopathy, a significant survival benefit of cabbage appearing after 5 years in comparison to optimal medical therapy, and that's despite the fact that 20% of the optimal medical therapy group actually had crossed over to cabbage. So here are the 3 reasons for the persisting survival benefit of cabbage over PCI. I've been showing this slide for the best part of 20 years. I've hardly changed it, and this is the bit that most cardiologists do not get when every time they say, forget all the previous history because we now have a new stent. The main fundamental difference between cabbage and PCI is that anatomically atheroma is mainly located in the proximal coronary artery. So by placing bypass grafts to the mid-coronary vessel, it has 2 effects. It means the complexity of the proximal culprit lesion becomes irrelevant, and it means that over the longer term, cabbage offers prophylaxis against future proximal culprit lesions. In contrast, PCI only treats suitable localized proximal culprit lesions, but has no prophylactic benefit against the development of new disease. The second thing is, as Tom Lusser showed us more than 3 decades ago in the New England Journal of Medicine, is the internal mammary artery elutes nitric oxide into the coronary circulation, thereby reducing the risk of further disease. In contrast, a drug-eluting stent placed in the proximal coronary circulation impairs re-endothelialization, causes downstream endothelial dysfunction, and creates a prothrombotic environment. And the third difference is that for many patients, PCI means incomplete revascularization. And this has been repeatedly shown in multiple studies over decades that incomplete revascularization leads to a subsequent increase in mortality and the risk of MACE. So I would argue that for these 3 reasons, PCI is unlikely to ever match the results of cabbage for most patients with multivessel or left main disease. It didn't with balloon angioplasty, it didn't with bare metal stents, it didn't with drug-eluting stents, and it has not done so with the new generation of drug-eluting stents. And if you understand these 3 different pathophysiological effects, you can understand why whenever I hear someone saying, you can forget all the previous history because we now have a new stent, it fails to take this into account. Very briefly, the ESC-EACTS guidelines shows that for 3-vessel disease, almost 80% of patients have a syntax score above 22. They have a class 1A indication for cabbage and class 3 for PCI, meaning you shouldn't do it. And those indications for cabbage are extended in patients with diabetes. But I would also argue if in cabbage there was more use of arterial grafts and better medical therapy, then the differences between cabbage and PCI would be even greater. I'll finish with this slide from the ESC-EACTS guidelines, which basically say, however, once you've looked at all the evidence, use your common sense. If you have an elderly, frail patient with relatively straightforward coronary artery disease and who also maybe has major comorbidities, that patient should have PCI. On the other hand, if you have younger patients with severe multivessel disease, particularly in the presence of diabetes and reduced LV function, these patients in the initial circumstance should be considered for cabbage. On that point, I'm going to conclude my talk. I would like to thank the organisers again for the great privilege of being here today and you, the audience, for your attention. Thank you.
All right, a great talk, pro and cons from Dr. Bangalore and Dr. David Taggart. But really, I'm sorry to not too much time prepare for a discussion. So, but Antonio, anyway, I
have one question for Dr. Bangalore. With the result of this ischemia, knowing all the limitations that you stressed, why we make such a big deal about complete revascularization, and why we keep on calling complete and incomplete, like pregnancy and no pregnancy. There is a level of complete revascularization.
No, that's a great point. I can tell you that, we have a paper in the works looking at the complete revascularization in the ischemia trial. Greg Stone presented this last year. And what we are seeing is if you are anatomically completely revascularized in the invasive strategy in ischemia, there is actually a difference in CV death or MI. And in fact, when we were designing the trial, the one thing that we told the sites to do is if you are randomized to invasive, try to do your best possible revascularization. And that was, we emphasized on completeness of revasc, whether it's functional or anatomic.
Mm-hmm.
Perhaps I'll ask David a question. So you're criticizing intervention for a certain extent for attempting to evolve. But the fact is, your surgical colleagues are not evolving. They don't get, my patients don't get 3 arterial grafts. They get a lemur and 2 veins, despite the data that we keep giving them. And increasingly, patients with diabetes and left ventricular systolic dysfunction are turned down for cardiac surgery because the creatinine is 166 or the hemoglobin is 107. We see as interventional cardiologists the benefit of 3-vessel bypass surgery in diabetics with bad ventricles, but we need to persuade our surgical colleagues to do the operation.
So, Adrian, thank you. I completely agree with you. I think that's a very valid comment. And let me make this clear. I am not criticizing any randomized trials. Randomized trials, for what they're worth, are very valuable. What I criticize is the misrepresentation of what that trial showed. So if you take ischemia, it just talks about stable coronary artery disease as if these results apply to all patients. As I've said, this will be a disaster for patients who have severe coronary artery disease. And we saw the same in the EXCEL trial. EXCEL was presented in the literature as a trial of PCI versus CABG in left main. It was, but it was in highly selected patients with left main. And therefore, what I'm criticizing is a way that, even if inadvertently, the potential misrepresentation of the way the trials are presented in the literature. And I think ischemia is a particularly good example of how misleading a trial can be. On the basis of ischemia, the guidelines for coronary artery surgery were downgraded by a group of experts. So if a group of experts can't understand what was happening in the ischemia trial, what chance is there of the average practitioner getting it right?
I'd love to respond to that. So a couple of things. I don't think it's the trialist who misrepresent any trial. It's the way people interpret it. Clearly all randomized trials are applicable to the patients that were enrolled and what was done in the trials. And the other thing I want to say about the guidelines is please actually read the guidelines. There is a paragraph clearly suggesting that it was not ischemia which led to the downgrade. It was all the other trials, Barry 2D trial, MASS2, everything showing that there is no difference in mortality. And I must say, I don't know why we keep persevering about mortality difference. There are so many other reasons to revascularize. Reduction in spontaneous MI. If a patient is symptomatic, they will feel better faster. Reduction in cardiovascular death. What more do you need? I'm not sure this, fixation about all-cause mortality.
Okay. Thank you. I'm sorry for, a limited time, so we're going to move to the next session. Really thank you for hot discussion and joining us together.